building up your health, because the more optimized you are and the more things you prevent, just like making smart financial decisions, the more health hardships or financial hardships you can endure in retirement or postmenopausally or in your later decades of your life. So it really is preventative and optimization. It's a bundled deal. You couldn't really do one without the other.
Another point that we can talk about with menopause is often combined oral contraceptives are used as a carryover where someone is having symptoms but they're not quite menopausal, they're perimenopausal, and you use them as a bridge to HRT, which kind of makes sense and it kind of doesn't make sense. I am obviously not completely against synthetic estrogens and synthetic progestins, but if this individual is having some genitourinary syndrome of menopause or changes in libido or function as well, then I think, well, why not think about a bioidentical androgen or even a synthetic androgen? How is a synthetic estrogen, a synthetic progesterone? If you're on these molecules, yes, they're well studied, but a lot of bioidentical androgens and even synthetic androgens are quite well studied as well. Perhaps not recent studies, but there's many of them that are very well studied, including actually especially so in women, especially women that have had breast cancer, that have had a lot of activity at the estrogen receptor as well. These are things that for the right individuals should certainly be considered, because if you're on something like an oral contraceptive and you're perimenopausal or you're just barely menopausal, or perhaps you didn't meet the criteria for FSH or LH, or you've had a period recently that was kind of like a one-off or a random one, you have this really high SHBG and you have an extremely low free testosterone, and some of your symptoms are addressed, but many of them are worse.
Yeah, I think the perimenopausal window is very interesting because it could be 1 month for some women and then they're in menopause. Mm-hmm. And for some women, they can have these fluctuations for 2 or 3 years. And I think what happens is, we just wait until they meet the criteria. When I say we, I'm talking about the traditional medical model. When in actuality, I think, let's say I was going to design an optimal perimenopausal treatment for a woman that does have a lot of these fluctuations. Yeah. They have hot flashes 1 month, they don't the next. You can suppress the ovarian function. You could do that with just a synthetic progesterone or a progestin. But then you are going to have decreased estrogen signaling, which is not ideal for holding on to bone mineral density and addressing the genitourinary symptoms. And it's not going to address lean body mass either. Yeah. While I'm not, opposed to synthetic estrogens, I think if you are suppressing the ovaries with a synthetic progestin, you could add a bioidentical estradiol to that. You could add a bioidentical testosterone to that. And that would sort of be the ideal regimen in my mind. Yep. Is that done frequently in practice? Probably not, just because there's multiple moving parts and you have to make sure that your patient is going to be able to understand why things are being done, and are they going to be able to do 3 different things instead of one thing. It's an individualized approach. So if you have a woman who really wants to know what is 100% the most optimal and natural and best way to address this, then maybe you have a little bit more of a complex regimen. Whereas if you have a woman that says, I just want to take 1 pill and have this stabilized and then we'll address menopause when we get there, then you could be on the end of that where you have a synthetic estrogen and a synthetic progestin. And there's no products yet that have synthetic estrogen, synthetic progestin, and synthetic androgen in them. Mm-hmm. So I think that would be an interesting frontier for drug development, given how common osteoporosis and fractures are.
Yeah, that would be extremely interesting, especially during the perimenopausal time, where a lot of your risks are lower, but you're really stockpiling. It's true preventative medicine to avoid things like that. And even as healthcare providers that concentrate on health optimization, a lot of health optimization is actually just disguised true preventative medicine. You do get an increase in quality of life and an increase in health span, but the lion's share of the benefit comes in preventing osteoporosis, preventing diabetes, preventing insulin resistance, preventing a decrease in muscle mass or sarcopenia, even preventing osteopenia. So a lot of those preventative measures, that's where you get 90% of the benefit.
Yeah, I agree, and it brings us back to that sort of analogy we used earlier. Your savings for retirement, or you're building up for that transition later in life when things start to go the other direction.
Yeah.
So you're building up your health, because the more optimized you are and the more things you prevent, just like making smart financial decisions, the more health hardships or financial hardships you can endure in retirement or postmenopausally or in your later decades of your life. So it really is preventative and optimization. It's a bundled deal. You couldn't really do one without the other.
Yep, they are synonymous, and you do both at the same time.